Good evening, everyone. Consultants, fellows, colleagues on the call. Once again, I want to welcome you all to this presentation. Today we have our colleague, Dr. Ozo Chibuke Innocent, to be leading the discussion on the 2024 ESC guidelines on the management of atrial fibrillation. Dr. Ozo, thank you. Please, your audience.
Okay, thank you. Good evening, my chiefs and consultants. Want to welcome everyone to this Saturday's presentation. And in this presentation, we'll be discussing the 2024 European Society of Cardiology guidelines on the management of atrial fibrillation. So in a bit to have a comprehensive understanding of our discussion today, it is important for us to understand a few terms. The first term which we need to understand is first the classes of recommendations. And we have three classes of recommendations. The class one is a proven evidence or general statement that a given treatment or procedure is beneficial, useful, or effective. And if any proven treatment or procedure is considered very, very beneficial, then it is recommended or is clearly indicated and placed as a class one level of class one recommendation. However, in class two, you have procedures that have conflicting evidence, or a procedure or a treatment has divergent opinion. For instance, here we might have an answer. People have a good explanation to that answer, or we may have two answers. Some group of people have a good explanation to one answer, while some group of people have a good explanation to the answer which they chose. In the sense that we have different school of thoughts with different answers and then good explanation. So in situations whereby you have a conflicting evidence or a divergent of opinion about the usefulness or efficacy of a given treatment or procedure, then it is placed under class 2 level of recommendation. In that class 2, we have class 2A and class 2B. The class 2A is a situation whereby the weight of evidence or opinion is in favor or usefulness of that procedure or treatment or efficacy. In that instance, if the benefit outweighs the other side, then it should be considered. Then for the class 2B, if the usefulness or efficacy is less well established by evidence or opinion, then it may actually be considered. Then the class 3 level of evidence is a situation whereby the evidence or general statement that the given treatment or procedure is not useful, effective, or in some cases may be harmful, then it shouldn't be recommended at all. So when it comes to the level of evidence, we also have three levels of evidence. The level A evidence, in which the data supporting the treatments or procedure, if the data is derived from multiple randomized clinical trials or meta-analysis. We all know that a randomized control trial is a scientific experiment that compares the effect of different treatments on a group of people. And they are usually considered gold standard for establishing cause and effect relationship in any clinical research. So any treatment or procedure being offered to a patient that has been subjected to multiple randomized controlled clinical trials. In most cases, you have different center trials, or one of them is a hypertension trial that was done in different countries and all that. If we have a study like that to prove that a particular treatment option or procedure was derived from multiple randomized clinical trials or meta-analysis, then it has a level 1 evidence. Then for the level B evidence, the data usually derived from a single randomized clinical trial or a large non-randomized clinical trial, in which case it falls into level of evidence B. The level of evidence C, when there's a consensus opinion of experts or small studies in retrospective studies or registries. Here now, we have a lot of consultants. Some consultants can believe this is the best way to go about this, or this one may believe this is the best way to go about this one may believe these are expert opinions. So when we have situations like this coming from expert opinions, we put it on that level of evidence C. Now, by way of introduction, we all know that atrial fibrillation is the commonest arrhythmia encountered in clinical practice, and also has strong associations with other cardiovascular diseases such as heart failure, coronary artery disease, valvular heart disease, diabetes mellitus, and hypertension. And in most cases, this may be a risk factor complication relationship. Now, the exact mechanism by which cardiovascular risk factors predispose to atrial fibrillation are not fully understood, but may include catecholamine excess, hemodynamic stress with attendant chronic endothelial injury, atrial ischemia, atrial inflammation, metabolic stress, and then neurohormonal cascade activation are all purported to promote atrial fibrillation and also propagate it. Now, the prevalence of atrial fibrillation is expected to double in the next few decades as a consequence of the aging population, an increasing burden of comorbidities, improved awareness, and new technologies for detection. Before we have first onset atrial fibrillation, then we also have paroxysmal atrial fibrillation. If a patient has paroxysmal atrial fibrillation and you do a resting ECG when the AFib is not there, you may actually not pick atrial fibrillation. So you may actually say this person does not have atrial fibrillation, despite the person complaining of symptoms like palpitations or thereabout. However, with the onset of Holter monitoring and device and all these smart wristwatches that can check blood pressure, that can check pulse rate and all that, some of them can even detect. There are some BP machines that can detect atrial fibrillation and all that. So with the onset of that, we're able to diagnose, albeit not previously diagnosed, cases of atrial fibrillation. And now, because of improved healthcare facilities and the aging population, we're able to also make the incidence of atrial fibrillation is now being on the increase. In situations whereby we didn't have good experts, good equipment in clinical care and all that, of course, when mortality rate was high, it was not, the extent of diagnosis was not this much. So it is important for us to know that atrial fibrillation is one of the supraventricular arrhythmias in which there is uncoordinated atrial activation, resulting in a loss of effective atrial contraction. It is reflected on the surface electrocardiogram by the absence of discernible and regular P waves and regular activation of the ventricles. This results in non-specific pattern to RR intervals in the absence of an atrioventricular block. It's important for us to know that we have to be sure that there's no AV block, which is bringing about this abnormal reading. Then over time, some patients with atrial fibrillation develop atrial and ventricular damage, which may make attempts at reading control futile. Then the effects of atrial fibrillation are variable across individual patients. However, morbidity from AF remains highly concerning. Patients with atrial fibrillation can suffer from a variety of symptoms, and those symptoms, such as stroke, heart attack, acute coronary syndrome, or even pulmonary embolism, may be the first symptom presentation of atrial fibrillation, especially in our environment where the health-seeking behavior is actually poor. So stroke and heart failure are consequences of atrial fibrillation, are now well appreciated by healthcare professionals. But atrial fibrillation is also linked to a range of other thromboembolic outcomes. Now, the typical drivers of atrial fibrillation onset and progression are a range of comorbidities and associated risk factors. So, most patients with atrial fibrillation may actually present without symptoms. Like I also said, most of them, the first presentation may come. The first presentation may also be a stroke. However, usually when patients are presenting, the first most presenting symptoms could be either palpitations, in which there's a feeling of a racing, fluttering, or pounding heart. Usually, sometimes people confuse anxiety for palpitations and all that. So, including we usually ask them to tap what they feel on the table. So, most people may also present with shortness of breath, chest pain, lightheadedness, tiredness, difficulty in exercising, and then even increased heart rate when we have atrial with a rapid ventricular response. So to achieve optimal care for patients with atrial fibrillation, it is now widely accepted that these comorbidities and risk factors must be managed early and in a dynamic way, and then sometimes individualized as well. Now, failure to do so contributes to recurrent cycles of atrial fibrillation, treatment failure, poor patient outcomes, and a waste of healthcare resources. Now, because of all this, the European Society of Cardiology Practice Task Force Guidelines on atrial fibrillation has consolidated and evolved past approaches to develop the atrial fibrillation care framework, which is actually the center point of the atrial fibrillation guidance, European Society of Cardiology atrial fibrillation guidance in 2022. So, and this atrial fibrillation care framework is aimed at achieving patient-centered atrial fibrillation management. And the components to achieve this optimal care, according to the AF care, include, first of all, comorbidity and risk factor management, avoid stroke and thromboembolism, then reduce symptoms by both rate and rhythm control, as the case may see, and then evaluation and dynamic reassessment. Then also lifestyle recommendations, psychosocial support, education and awareness for patients, education of patients, families and members and family members and caregivers is essential, because sometimes when most patients need to be on anticoagulation, you may give them 1 month of appointment and they think they are well and then they come back again. Then how do we implement this atrial fibrillation centered approach management, AF management? First of all, it's important to have a model of shared decision making. Please, I don't know, in case I'm not heard, please, someone should know its network and then I could be reached out to the call, please, because if I'm just speaking, I may not really know when I've gone out. Then we must ensure multidisciplinary team approach, electrophysiologists, cardiologists, interventional cardiologists, and all that. Then patient education and empowerment with emphasis on self-care, structured education programs for healthcare professionals so that there's always a continuous medical education program. Then technology support, e-health, m-health, and telemedicine all directed towards remote monitoring, especially in areas where there may be a risk or high chance of loss of patients to follow up. So as we continue, first of all, there are some important terms to understand in the definition of atrial fibrillation. First of all, please, just a few minutes. Sorry, so first diagnose atrial fibrillation. This is atrial fibrillation that has not been diagnosed before, regardless of the symptoms, and then pattern or duration. Remember, I mentioned that in the past, most people that complain of palpitations, we may just do a resting ECG for them, and we may not really have those, the ECG may be normal if the AFib is proximal. To take care of that, by we're not able to have the smartwatches, other smart devices, and especially Holter ECG monitoring that the patient can use 24 hours, 48 hours, and even 2 weeks, depending on the capacity of the Holter itself, so that it can help us diagnose all this and then properly classified. Then we have the proximal atrial fibrillation, which terminates spontaneously within 7 days. It may terminate spontaneously or terminates with the aid of intervention. And then there is strong evidence to support that most of these proximal atrial fibrillation usually do not last more than 48 hours. Then we have persistent atrial fibrillation, which are AF episodes which are not self-terminating. And then many intervention trials may not take care of this within 7 days. And then we also have the long-standing persistent atrial fibrillation, which is an arbitrary term defined as a continuous AF that has lasted more than 12 months. But the difference here between long persistent atrial fibrillation and permanent atrial fibrillation, that even though it has lasted more than 12 months, you can still achieve rhythm control. Rhythm control is still possible. Now, for the permanent atrial fibrillation, rhythm control is not possible, and there has to be an agreement between the patient and the physician and say, let us just focus on rate control. The other important clinical concept that we must understand relevant to atrial fibrillation. One of them is clinical atrial fibrillation, which is diagnosed clinically. Then, however, based on the new recommendation, when you diagnose atrial fibrillation clinically, it is important for you to also go ahead and do an ECG, a standard ECG, to actually support your diagnosis. So before you can do a pulse rate and you get an irregular pulse, but we also know that it's not only atrial fibrillation that can give us an irregular pulse. You can also calculate the heart rate and you get a pulse deficit. However, the standard is that you also do a standard ECG to confirm your diagnosis, because it is not just atrial fibrillation that can give you an irregular pulse. Now, device detected or subclinical atrial fibrillation. We have mentioned that there are some instances of atrial fibrillation, especially paroxysmal, that may not be picked up by resting ECG machines. However, with the advent of smart devices and then Holter monitoring, we're able to do 24 hours Holter, 48 hours Holter, and then even 2 weeks Holter monitoring to diagnose, albeit or previous atrial fibrillation episode that were not diagnosed by the resting ECG machine. Now, the overall time spent in atrial fibrillation during a clearly specified and reported monitoring time, expressed as a percentage of time, it is referred to as the atrial fibrillation burden. There's also a recent onset atrial fibrillation. So if you have been following up a patient and the patient has not been having atrial fibrillation, let's assume the patient, you saw the patient last week, there was no atrial fibrillation, and the patient comes in follow up this week, and if you now notice that the patient has atrial fibrillation, you do an ECG, you confirm that that is termed recent onset atrial fibrillation. You also have the triggered or induced atrial fibrillation, which is a new episode in close proximity to a precipitating or potentially risk factor. Now, you may have a patient who was not possibly taking. There are lots of patients that were not having it, or let me say, there are lots of people that were not having atrial fibrillation. Maybe for one reason or the other, they get depressed, they start taking alcohol, they start smoking, and then they start abusing drugs, or even taking CNS stimulants. Some of them may now have what we call triggered atrial fibrillation. Then we have early atrial fibrillation, which is the time since diagnosis that qualify for early AF is dissociated from underlying atrial cardiomyopathy and is not well defined. We also have the self-terminating atrial fibrillation, which is a paroxysmal that may terminate spontaneously. We have the non-self-terminating atrial fibrillation, which does not terminate spontaneously except use an intervention. And then you also have atrial cardiomyopathy, in which is a combination of both structural, electrical, or functional changes in the atrium due to what the onset of, due to maybe triggered atrial fibrillation or atrial fibrillation developing from any other cause. Then before, we didn't have classification model to classify atrial fibrillation. What we just know is that when a patient comes down with atrial, with palpitations and all that, we evaluate and then we discover the patient has atrial fibrillation. We start management. However, there's a new device model, which is the Modified European Heart Rhythm Association classification model for atrial fibrillation, and then it has a score. Score 1 is that the patient is asymptomatic. Most patients with asymptomatic atrial fibrillation falls within this group, and the atrial fibrillation does not usually cause any symptom. Then 2, we now have people that are asymptomatic, but the symptom might be mild or moderate. However, in this instance, for the mild patient, normal daily activity is not affected by symptoms related to atrial fibrillation. So this is actually, to some extent, if we can liken it to the New York Association classification for heart failure. Then the 2B, moderate, normal daily activity, not affected by symptoms related to atrial fibrillation, but troubled by symptoms. And then we have the severe and then the disabling. So for diagnostic workup for patients with atrial fibrillation, it is advised that we begin both from history, physical examination, and then all forms of diagnostic workup, medical history taken to determine the AF pattern. Of course, if you say a patient last week and then the patient comes and said in between the period you saw the patient and now, the patient had palpitations and it was not there during the clinic, then there's a high chance that the patient was actually having probably a paroxysmal or first onset atrial fibrillation. It is important to assess symptoms and functional impairment using transthoracic echocardiography. Please, I'm trying to rush this thing because it's actually so much. So in terms of diagnosis workup for atrial fibrillation, part of the guideline recommend that just like we manage a patient fully, we start from history taking, we start from bedside ECG, we start from echocardiography. Sometimes you may do genetic studies for mapping and all that, and then you may also do what we call gene mapping and all that, and then you can do different forms of either transthoracic or transesophageal echo, and then you also apply the atrial fibrillation care model management decision. And then sometimes you may want to do brain imaging and then cognitive functional impairment in some patients too. Now, we have said that unlike before, when people will feel a pulse and then get irregular pulse and then check the heart rate and then they compare the pulse deficit, it is recommended that once you make a clinical assessment of atrial fibrillation, please support it with a 12-lead ECG and then commence risk stratification and treatment based on relevant treatment guidelines. Then evaluating the impact of atrial fibrillation-related symptoms is recommended before and after major changes in treatment to inform shared decision-making and guide treatment choices as well. We have said that the transthoracic echocardiogram is recommended in patients with atrial fibrillation when this will guide treatment decisions. Sorry, let me change this so that we can. Hello, are we still here?
So we can hear you.
Go ahead.
Okay. So other recommendations for patient-centered care and education, we have said that education is important to both patients, family members, and caregivers, as well as healthcare professionals, because you can see that in postgraduate environment like federal medical centers, teaching hospitals and all that, what happens there seems to be different from what happens in private hospitals and all that, so that there's a kind of difference in treatment models. So some of them do not really understand some of these guidelines. They don't even use it at all. So education, both on the part of the patient and healthcare professionals, is very, very important. So now, having borne that in mind, there are actually some salient new recommendations in the 12, about 14 of them in this current European Society of Cardiology guidelines for 2024. And the recommendations are based on different parameters. First of all, one is the diagnostic evaluation of new atrial fibrillation. It's recommended that a transthoracic echocardiogram is recommended in a patient with atrial fibrillation AF diagnosis, where this will guide treatment decisions. Of course, it's always important. Then we must always apply the principle of the AF care in management of atrial fibrillations. We assess the comorbidity, we assess the risk of close, we assess the risk of stroke, and then reevaluate, and then other modalities. Now, we also have the comorbidities and risk factor management. Now, if we have a patient with different comorbidities, there are some salient things we must do for that patient. If we have a heart failure patient, for instance, that has atrial fibrillation and the patient is congested, it's recommended that diuretics are recommended in patients with atrial fibrillation and heart failure, and also have congestive symptoms to alleviate such symptoms and facilitate better atrial fibrillation management. This is actually a class 1 indication with the level of recommendation C. Then the second new recommendation, still part of the AF care framework, is that appropriate medical therapy for heart failure is recommended in patients with heart failure and impaired left ventricular ejection fraction to reduce symptoms and or heart failure hospitalizations and prevent heart failure recurrence, or rather to prevent atrial fibrillation recurrence. Then it is also recommended that sodium glucose transportation inhibitors are recommended for patients with heart failure and atrial fibrillation, regardless of the left ventricular ejection fraction, to reduce the risk of heart failure hospitalization and cardiovascular death. Then it's important to achieve effective glycemic control wherever it becomes necessary, either by the use of bariatric surgery, use of GLP-1 agonists such as semaglutide, I think relaglutide, Mounjaro, and the rest of them, as the case may be. The management of obstructive sleep apnea may be considered as a part of a comprehensive management of risk factors in individuals with atrial fibrillation to reduce recurrence and progression. So if a patient has atrial fibrillation and that patient also has sleep apnea, it's recommended that you don't just focus treating on the atrial fibrillation and also forget evaluation of the sleep apnea, because if you don't do that, the patient, the atrial fibrillation can actually recur in this patient because of that underlying precipitant. Then, when you screen for patients with atrial fibrillation, using only symptom-based questionnaire is not recommended. Very important. Then, in the course of use of oral anticoagulation, it is recommended in patients with clinical atrial fibrillation at elevated thromboembolism risk to prevent ischemic stroke and thromboembolism. A Chadva score for 2 is more is recommended as an indicator of elevated thromboembolism risk for decision on initiating oral anticoagulation. So in the part of the new guideline, it's recommended that once a patient has a Chadva score of 2 or more, it is important that you risk stratify this patient and commence as soon as possible and commence oral anticoagulation as soon as possible. However, if the patient has amyloidosis or the patient has a hypertrophic obstructive cardiomyopathy, even when the patient has a Chadva score of 1, it is important that such patient be worked off for oral anticoagulation. Now, the S in the S, which we had initially in Chadva, was removed because sex has been seen as a risk modifier and not a risk factor. The recommendations on the initiation of oral anticoagulant. Individualized reassessment of thromboembolism is recommended at periodic intervals in patients with atrial fibrillation to ensure anticoagulation is started in appropriate patients. So what this actually goes on to explain is that if we have patients with atrial fibrillation, it is important for us to make a plan to offer the patient oral anticoagulation, bearing in mind the comorbidity status of this patient. Now, it's important to understand that direct oral anticoagulants are not inferior to warfarin for prevention of thromboembolism. And then it also has 50% reduction of ischemic stroke, intracerebral hemorrhage, and stroke, and then systemic embolism and mortality as well. Then DOACs are safe when the DOACs are recommended based on the based
In a
on
seatbelt there
eGFR.
for children.
You said? So is the person talking to me?
I don't think so. I think the person joined on YouTube. Yeah, can you go ahead?
Okay, thank you. So now a reduced dose of DOAC, a direct oral anticoagulant therapy, is not recommended unless patient meet DOAC-related specific criteria to prevent underdosing and avoidable thromboembolic risk. There are some instances. Now, for atrial fibrillation, the ASU recommended dose is 20 milligrams. However, there are also the dose varies. That's that's for rivaroxaban. The dose varies for different oral anticoagulants. We may use rivaroxaban, apixaban, edoxaban based on the eGFR recommendation. Now, we can use rivaroxaban, apixaban, and edoxaban when the GFR falls between 15 to 29. And then if the patient has chronic kidney disease, apixaban is usually actually more preferred. However, if the patient is undergoing hemodialysis, about 2.5 milligrams of apixaban morning and BD is preferred, or the use of warfarin. And then direct oral anticoagulants should also be avoided in situations where the patient have moderate to severe mitral stenosis or metallic prosthetic valve. However, one may actually, in these instances, one may prefer to switch to DOACs if the time and therapeutic ratio is less than 70%, or the patient has an increased risk of intracerebral hemorrhage. Then for residual ischemic stroke despite anticoagulation, if a patient has residual ischemic stroke despite oral anticoagulation, it is important that other non-cardioembolic causes of thromboembolism be evaluated, and then other vascular risk factors, and then you also have to look at the dosage and then probe on patient adherence. And then addition of antiplatelet treatment to anticoagulation is not recommended in patients with atrial fibrillation to prevent recurrent embolic stroke. So if a patient keeps having recurrent embolic stroke, there is no need to add antiplatelet treatment to enhance anticoagulation. If we have these instances, it is better to look elsewhere as the possible source of the atrial possible source of the thromboembolic event. Now, surgical left atrial appendage occlusion. Surgical closure of the left atrial appendage should be considered as an adjunct to oral anticoagulation in patients with atrial fibrillation undergoing endoscopic or hybrid atrial fibrillation ablation to prevent ischemic stroke and thromboembolism. Then standalone endoscopic subacute closure of the left atrial appendage may be considered in patients with atrial fibrillation and contraindications for long-term anticoagulation treatment to prevent ischemic stroke and thromboembolism. Now, if a patient maybe has had an intracerebral hemorrhage, or a patient has upper gastrointestinal bleed, or for whatever reason, and the patient keeps having a recurrent thromboembolic phenomenon, then it is important to do standalone endoscopic surgical closure of the left atrial appendage in such instances, rather than falling into confusion. Then management of bleeding on anticoagulation therapy. Specific antidote should be considered in atrial fibrillation patient on DOAC who develop a life-threatening bleed or bleed into a critical site. Of course, we all know that some of these oral direct oral acting anticoagulants, some of them now have antidotes like dabigatran, which is actually the one that is most renally excreted and can be used in EGFR far less than 30. The antidote is idrasuzumab, while that for rivaroxaban is andexanet alpha, but I don't think that is readily available in Nigeria at the moment. Now, management of heart rate in patients with atrial fibrillation. Weight control therapy is recommended in patients with atrial fibrillation as initial therapy in the acute setting and as an adjunct to rhythm control therapy, or a sole treatment strategy to control heart rate and reduce symptoms. We all know that rate control becomes the sole treatment option, especially in situations whereby we have permanent atrial fibrillation. Then beta blockers, diltiazem, verapamil, or digoxin are recommended as first choice drugs in patients with atrial fibrillation and left ventricular ejection fraction of greater than 40% to control heart rate, and then reduce symptoms. Of course, we won't use beta blockers and non-dihydropyridine group of calcium channel blockers so that we don't bring about a complete heart block. Then AV nodal ablation combined with cardiac resynchronization therapy should be considered in severely symptomatic patients with permanent atrial fibrillation and at least one hospitalization for heart failure to reduce symptoms, physical limitations, and then recurrent heart failure, hospitalization, and mortality. Now, the general principles guiding oral anticoagulation. Direct oral anticoagulant are recommended in preference to vitamin K antagonists in eligible patients with atrial fibrillation undergoing cardioversion for thromboembolic risk reduction. Then cardioversion for atrial fibrillation, either electrical or chemical, should be considered in somatic patients with persistent atrial fibrillation as part of a rhythm control approach. And then a wait-and-see approach for spontaneous conversion to sinus within 48 hours of atrial fibrillation onset should be considered in patients without hemodynamic compromise as an alternative to immediate cardioversion. So if you have a patient presenting at least within 48 hours and the patient is not in any hemodynamic imbalance, it is advised that you treat, wait, and then watch the outcome. The implementation of a rhythm control strategy should be considered within 12 months of diagnosis in selected patients with atrial fibrillation at risk of thromboembolic events to reduce the risk of cardiovascular death or hospitalization. So if a patient is diagnosed with atrial fibrillation, it is recommended at least within 12 months of onset of that diagnosis that you should commence rhythm control for that patient. And then early cardioversion is not recommended without appropriate anticoagulation or transesophageal echocardiogram if atrial fibrillation duration is longer than 24 hours, usually 48 hours, or there is a scope to wait for spontaneous cardioversion. However, that is if the devices are available for that. So electric cardioversion as a diagnostic tool should be considered in patients with persistent atrial fibrillation where there is uncertainty about the value of sinus rhythm restoration on symptoms or to assess improvement in left ventricular function. Then use of antiarrhythmic drug therapy is not recommended in patients with advanced conduction disturbances unless antibradycardia pacing is provided. So if you want to give antiarrhythmic regimen, in this instance, you have to make available for antibradycardia pacing. Then if there's a patient with sinus node disease or tachycardia bradycardia syndrome, atrial fibrillation, atrial AF catheter ablation should be considered in patients with AF-related bradycardia or sinus pulse or AF termination to improve symptoms and avoid pacemaker implantation. So the direct treatment model here is AF catheter ablation. Then if a patient has repeat AF after catheter ablation, this patient should be considered in patient with atrial fibrillation recurrence after initial catheter ablation, provided the patient's symptoms were improved after the initial procedure or after failed initial to reduce symptoms, recurrence, and then progression of AF. And if a patient has repeat AF after catheter ablation, those patients may actually be considered for a candidate for MACE procedure, in which you map a whole region of places where you have all those abnormal rhythm discharges so that you can then ablate them. The MACE procedure can work in those instances. Then uninterrupted oral anticoagulation is recommended the patient undergoing atrial fibrillation catheter ablation to prevent peri-procedural ischemic stroke and thromboembolism. Then continuation of oral anticoagulation is recommended in patients with atrial fibrillation at elevated thromboembolic risk after concomitant endoscopic or hybrid atrial fibrillation ablation independent of rhythm outcome or left atrial exclusion to prevent ischemic stroke and thromboembolism. And then endoscopic and hybrid ablation procedure should be considered in patients with symptomatic persistent atrial fibrillation constant to therapy to prevent symptoms, recurrence, and progression of atrial fibrillation within a shared decision-making rhythm control team of electrophysiologists and surgeons. If we have patients with acute or chronic coronary syndromes and also having atrial fibrillation, the recommendation is that for AF patients with these instances, antiplatelet therapy within 12 months is not recommended in stable patients with chronic coronary or vascular disease treated with oral anticoagulation due to the lack of efficacy and to avoid major bleeding. Therefore, trigger-induced atrial fibrillation, long-term oral anticoagulation should be considered in suitable patients with trigger-induced atrial fibrillation at elevated thromboembolic risk to prevent ischemic stroke and systemic thromboembolism. Then, in patients with post-operative atrial fibrillation, perioperative amiodarone therapy is recommended where drug therapy is desired to prevent a post-operative atrial fibrillation after cardiac surgery. However, we must do risk assessment to look out for patients that can fall into this category. Then concomitant posterior pericardiotomy should be considered in patients undergoing cardiac surgery to prevent post-operative atrial fibrillation. Then there's the concept of the embolic stroke of unknown source. Then initiation of oral anticoagulation in patients with embolic stroke of an unknown source without documented atrial fibrillation is not recommended due to lack of efficacy in preventing ischemic stroke and thromboembolism. So if you have patients that that have embolic stroke, in which case you are not sure of the source, there's no need for the initiation of oral anticoagulation. The oral anticoagulation is recommended in patients with atrial flutter at elevated thromboembolic risk to prevent ischemic stroke and thromboembolism. Then there are also screening strategies for atrial fibrillation. I think we mentioned this before. I'll just proceed. Then we also have recommendation for primary prevention of atrial fibrillation. Maintaining optimal blood pressure control is recommended in general population to prevent atrial fibrillation with ACE inhibitors or ARBs as first-line therapy. However, this primary prevention is directed towards risk factors, patients that are hypertensive, patients that are obese, patients that are chronic alcoholics, patients that abuse recreational drugs, and then patients that also smoke. So for those that are hypertensive, adequate blood pressure lowering medications is recommended. Then weight reduction for patients that are obese, smoking cessation, and then moderation of alcohol intake for patients that are alcoholic, and then also maintaining adequate lifestyle is also recommended with an equivalent of 150 to 300 minutes of per week of moderate intensity exercise, or 75 to 150 minutes per week of vigorous intensity aerobic physical activity. And then avoidance of binge drinking or alcohol exercise. This primary prevention for atrial fibrillation is directed towards risk factor modulation. Then this is a comparison of previous guidelines and then the 2024 guidelines. I think we have talked about this. So confirmation by ECG is recommended, and then for the diagnosis of atrial fibrillation, and then risk stratification and treatment. So recommendation for comorbidity. Recommendation for oral anticoagulation in atrial fibrillation. We have said that direct oral anticoagulants are recommended in patients in preference to vitamin K antagonists to prevent ischemic stroke and thromboembolism event, except in patients with mechanical heart valves or moderate to severe mitral stenosis. And we have said that VKS are preferred in these two instances. However, if treatment to therapeutic time is less than 70% in this patient with moderate to severe mitral stenosis, or they have mechanical heart valve, or there's a high increase of intracerebral hemorrhage, then I think low dose direct acting on oral anticoagulant is recommended. Then maintaining vitamin K antagonist treatment rather than switching to direct oral acting anticoagulants may be considered in patients aged greater than 75 years or clinical stable therapeutic VKA with polypharmacy to prevent excess bleeding. So if a patient has been on VKA, there's no need switching to DOACs, especially if that patient age is above 75 years. Then a reduced dose of DOAC therapy is not recommended except in certain specific conditions, such as chronic kidney disease and all that. So these are the various treatment. These are the various doses, and then creatinine levels in which each of them can be used. So we have said that if patients are on oral anticoagulants and maybe by one reason or the other, they find themselves bleeding, depending on what they are. If they were taking direct oral anticoagulants, we use the necessary antidotes, such as idrasuzumab for dabigatran, or andesonate alpha for rivaroxaban, and then prothrombin complex concentrates, especially in patients on with atrial fibrillation that are on vitamin K and antagonists. The rate control therapy is recommended in patients with atrial fibrillation as the initial therapy in the acute setting, and adjunct to rhythm control therapy, or as a sole treatment strategy to control heart rate and reduce symptoms. So these are the various drugs, and then various drug for rate control in atrial fibrillation, and then their respective doses. We can go through them later. So recommendation for pharmacological cardioversion of atrial fibrillation. It's recommended that intravenous flecainide or propafenone is recommended when pharmacological cardioversion of recent onset AF is desired, excluding patients with severe left ventricular hypertrophy, heart failure, reduced ejection fraction, or coronary artery disease. So these are patients that you may not want to use intravenous flecainide or propafenone. Then intravenous venacalant is recommended when pharmacological cardioversion of recent onset atrial fibrillation is desired, excluding patients with recent acute coronary syndrome, heart failure, reduced ejection fraction, or severe aortic stenosis. Then intravenous amiodarone is recommended when cardioversion of atrial fibrillation in patients with severe left ventricular hypertrophy, heart failure, reduced ejection fraction, or coronary artery disease is desired, accepting there may be a delay in cardioversion. Then a single self-administered oral dose of flecainide or propafenone, which is called pill in the pocket, should be considered for patient-led cardioversion in selected patients with frequent paroxysmal atrial fibrillation. This is done by the patient after efficacy and safety assessment, and excluding those with severe left ventricular hypertrophy or heart failure, reduced ejection fraction, or coronary artery disease. Then pharmacological cardioversion is not recommended for patients with sinus node dysfunction, atrioventricular conduction disturbances, or prolonged QT interval greater than 500 milliseconds, unless risks of proarrhythmia and bradycardia have been considered in such patients. So the recommendations are much, but I think I gave a general summary to all of them. I'll just go straight there. So the summary of the key points of the European Society of Cardiology 2024 guideline is one, that the guideline document recommend treatment using the atrial fibrillation care pathway, which is comprised of C, comorbidity and risk factor management, avoiding stroke and thromboembolism, reducing symptoms by rate and rhythm control, and then evaluating and reassessing as patient's disease and comorbidities progress. Now, joint decision-making regarding the best option for atrial fibrillation management should be made between the patient and the provider, supported by a multidisciplinary team. Education for patient, family members, caregivers, and healthcare professionals is recommended. Then for patients with comorbidities, hypertension, heart failure, diabetes mellitus, obesity, obstructive sleep apnea, physical inactivity, and high alcohol intake should be evaluated and managed to avoid recurrences and progression of atrial fibrillation, improve success of atrial fibrillation treatment, and prevent atrial fibrillation-related outcomes. Then appropriate medical therapy for heart failure is recommended in atrial fibrillation patients with heart failure and impaired left ventricular ejection fraction to reduce symptoms and/or heart failure hospitalization and prevent atrial fibrillation recurrence. Then sodium glucose transporter inhibitors are recommended for patients with heart failure and atrial fibrillation, regardless of left ventricular ejection fraction, to reduce the rate of heart failure hospitalization and cardiovascular death. Then metformin or sodium glucose transporter inhibitors should be considered for individuals needing pharmacological management of diabetes mellitus to prevent atrial fibrillation. Then weight loss recommended as part of comprehensive risk factor management in overweight and obese patients with atrial fibrillation to reduce symptoms and atrial fibrillation burden with a target of greater than 10% reduction in body weight. The management of obstructive sleep apnea may be considered as part of a comprehensive management of risk factors in individuals with atrial fibrillation to reduce recurrence and progression when screening for obstructive sleep apnea in individuals with AF. Using only symptom-based questionnaires is not recommended. Then a tailored exercise program is recommended in individuals with proximal or persistent atrial fibrillation to improve cardiorespiratory fitness. Then reducing alcohol consumption to less than 3 standard drinks or 30 grams of alcohol per week is recommended as a part of comprehensive risk factor management to reduce atrial fibrillation. And then four points, assessment of the risk of thromboembolism may be done with locally validated risk tools such as the CHA2DS2-VASc score and assessment of other risk factors. Then oral anticoagulation are recommended CHA2DS2-VASc is greater than 2 atrial fibrillation, and the patient has obstructive cardiomyopathy, even if the CHA2DS2-VASc is 1, coagulation commenced. Then there of these heart valves or mitral stenosis. And we have also therapeutic ratio of intraoral anticoagulants are not indicating direct oral anticoagulants. And then addition of antiplatelet treatment to oral anticoagulants is not recommended in atrial fibrillation patients for the goal of preventing ischemic stroke or thromboembolism. And then anticoagulant and antiplatelet agents should not be combined unless the patient has an acute vascular event or needs entering treatment for such procedures. The anticoagulation should be pursued according to the patient's individual risk of thromboembolism, irrespective of whether they are in atrial fibrillation or in sinus rhythm. And the oral anticoagulation is recommended in all patients with atrial fibrillation and hypertrophic cardiomyopathy or cardiac amyloidosis, regardless of the CHA2DS2-VASc score. Then a reduced dose of DOAC therapy is not recommended unless patient meets DOAC-specific criteria, especially if the patient has chronic kidney disease, to prevent underdosing and avoiding thromboembolic events. Because in such instances, if that is not taken into consideration, one may be tempted to look out for non-cardioembolic or non-vascular sources of thromboembolism. And another patient should be kept on oral anticoagulation for more than 2 months after an atrial fibrillation ablation procedure, irrespective of estimated thromboembolism risk. Then for a formal risk score-based assessment of bleeding risk, the has-bled score should be considered to help address modifiable bleeding risk factors and to identify patients at high risk of bleeding, especially if the has-bled score is greater than 3, or early and more frequent clinical review and follow-up. So this summary is actually, the summary of the ESC guideline is actually grouped completely into 7 classes, and I've mentioned the first 4. The 5th one is that beta blockers, digoxin or diazem of verapamil. DIGA blockers can be used at any ejection fraction. Digoxin can be used at any ejection fraction. However, the diazem of verapamil will be used if the left ventricular ejection fraction is greater than 40%, may be used as initial therapy as an adjunct to rhythm control therapies, or as a sole treatment strategy to control heart rate and symptoms. Then rhythm control should be considered in all suitable atrial fibrillation patients, including a cardioversion, antiarrhythmic drugs, and catheter or surgical ablation to reduce symptoms and morbidity. And this includes primary indication for rhythm control is reduction in the atrial fibrillation related symptoms and improvement in the quality of life. The implementation of a rhythm control study should be considered within 12 months of diagnosis in selected patients with atrial fibrillation at risk of thromboembolic event to reduce the risk of cardiovascular death, hospitalization. Then electrical cardioversion is a diagnostic tool, as a diagnosis should be considered in patients with persistent AF where there is uncertainty about the value of sinus rhythm restoration or symptoms, or to assess improvement in left ventricular function, or if the patient is in hemodynamic imbalance. Then catheter ablation should be considered as a second-line option if antiarrhythmic agents fail to control AF in patients with atrial fibrillation, or as a first-line option in patients with paroxysmal atrial fibrillation. And then repeat atrial fibrillation catheter ablation should be considered in patients with AF recurrence after initial catheter ablation, provided the patient's symptoms were improved after the initial pulmonary vein isolation, after failed initial pulmonary vein isolation to reduce symptoms, recurrence, and progression of the atrial fibrillation. Then seventh highlight of the guideline is for endoscopy or hybrid ablation should be considered if catheter ablation fails, or if as an alternative to catheter ablation in persistent atrial fibrillation despite antiarrhythmic drugs. Continuation of oral anticoagulation is recommended in patients with atrial fibrillation at elevated thromboembolic risk after concomitant endoscopy or hybrid atrial fibrillation ablation, independent of rhythm control outcome or left atrial appendage exclusion to prevent ischemic stroke and thromboembolism. An atrial fibrillation ablation during cardiac surgery should be performed in centers with experienced teams, especially for patients undergoing mitral valve surgery. Then surgical closure of the left atrial appendage should be considered as an adjunct to oral anticoagulation in patients with atrial fibrillation undergoing endoscopic or hybrid atrial fibrillation to prevent ischemic stroke and thromboembolism. And then most importantly, patients should be periodically reassessed with attention to new modifiable risk factors that could slow or reverse the progression of atrial fibrillation, increase quality of life, and then prevent adverse cardiovascular outcomes. This becomes important, especially, for instance, this patient may not really afford the recommended direct oral anticoagulants, in which case we may recommend the vitamin K antagonist for them. So it is important to educate them about the drug-drug interactions, which may affect the therapeutic anticoagulation range of 2 to 3.0 in patients with atrial fibrillation. So thank you for listening.
Thank you very much, Dr. Ozo. At this point, kindly ask your questions, contributions. You can type your questions in the chat box. and he will respond accordingly. Whilst we wait for contributions also, we want to acknowledge our senior members on the call. If they also want to make contributions, they can kindly go ahead. Thank you.
Oh, sorry. I'm just seeing this. Chief, I'm just seeing your message.
Oh, no problem. No problem.
Should I go back to those ones that I skipped?
Yeah, I think if you can go back to them because after
Okay, please. I'm just seeing your message now. Sorry, please. Let me go back there.
yeah, I think the timing is 2 hours. So as much as possible, you have
Oh,
to
okay.
take your time. Some of them, I think the ones that you went through it quickly, if you could just go back and take colleagues through it so that, for example, the combination of beta blockers with the digoxin from that side going in patients with low EF, I think you skip that part or you run
I
through
think
it.
I mentioned that.
Whilst you wait for them to ask questions. Or if there's any part that you wish to also re-emphasize, you can use this opportunity to do that. I think from here.
Yeah. Okay, we have said that beta blockers, diltiazem, verapamil, or digoxin are recommended as first choice drugs in patients with atrial fibrillation and left ventricular ejection fraction of greater than 40% to control heart rate and reduce symptoms. And then beta blockers and or digoxin are recommended in patients with atrial fibrillation and left ventricular ejection fraction less than 40% to control heart rate and reduce symptoms. However, if the left ventricular ejection fraction is greater than 40%, beta blockers, diltiazem, verapamil, or digoxin can be used. But specifically for patients with left ventricular ejection fraction less than 40%, beta blockers and digoxin are preferred because the non-dihydropyridine group of rate control agents may cause may worsen may worsen or rather may cause hypertension since the ejection fraction is actually reduced. Then combination rate control therapy should be considered if a single drug does not control symptoms or heart rate in patients with atrial fibrillation, provided that bradycardia can be avoided to control heart rate and reduce symptoms. So this in this instance, there's a room for combining rate control strategies. I think in this instance, beta blockers can be used with I think ivabradine or so, especially when the beta blockers are not controlling are not achieving good control during exercise. However, despite the room for combination of rate control therapies, we must also avoid the use of diltiazem and verapamil alongside beta blockers so that you don't trigger a complete heart block. Then linear rate control with a resting heart rate of less than 110 beats per minute should be considered as the initial target for patients with atrial fibrillation, with stricter control reserved for those with continued atrial fibrillation-related symptoms. This is because the atrial fibrillation on its own is a burden, and then if a patient that has other atrial fibrillation-related symptoms or even worsening of severe comorbidities, it is important to use a more modest rate control strategy so that we can give the patient a favorable diastolic filling time, not to adversely impair cardiac output.
Yeah, that's also just a clarification. You made mention
Yeah.
combining beta blockade with ivabradine in atrial fibrillation.
No,
I
no,
believe
sorry,
what
I think there's something I'm trying to remember. There's a drug you can use if especially if you're not getting good results with beta blockers, especially when you're doing exercise. I'm just trying to remember it, but I can't immediately remember. I'm just trying to in this situation whereby I'm just trying to emphasize in this situation whereby they said we can combine combination of rate control therapy should be considered if a single drug does not control symptoms in atrial fibrillation. So I also said that despite that is allowed, we should also be careful about the use of beta blockers and verapamil or diazepam so that we don't precipitate, we don't cause or till the patient is into a complete heart block. But I think there's also another drug that we can use alongside. We can use digoxin alongside the beta blockers. But I think there's another drug that we can use, especially if the patient, if they are not able to achieve good rate control during exercise for the patient. But I can't immediately remember.
Oh, okay, thank you. I just need that clarification because ivermectin is for sinus rhythm. But just as a reminder, remember there was a question where the interaction between digoxin and verapamil, where verapamil interferes with the P glycoprotein, so interferes with digoxin metabolism. So we should take note of that. It was one of the questions we saw.
Okay, thank you, Chief.
Please, any contributions or questions from our seniors? Let's show appreciation to our colleague Dr. Ozo for the presentation, combining the stress of our work, revision, individual learning, and still making time for slides. Okay, we have Dr. Prof. Dimeji's hands up. Prof, please, you can unmute, then ask the question, please.
Yeah, thank you very much for this fantastic presentation. Yeah, so I just have just one or two questions to ask. One is in patients with AF and have heart failure with reduced ejection fraction, there was a slide that talked about, I think slide recommendation 7, that talked about doing a CRT for them and even under ablation. So can you further buttress on that point?
Okay, they said if a patient has atrial fibrillation and then heart failure, one of the things you want to do is that you may want to do catheter ablation for that patient to improve symptoms, and then cardiac and then do a CRT for that patient to achieve maximum improvement in symptoms.
So we need to understand what you mean by your catheter ablation. Are you doing catheter ablation to convert to sinus rhythm?
Okay, now, Chief. Okay, now, Chief, there are some instances that you may have a patient with atrial fibrillation. However, they are not responsive to ideal rhythm control regimens. In such patients will benefit from catheter ablation. So I don't know if I've answered your question.
No, so I think you need to get some important information very clear. Okay? So when you talk about doing catheter ablation for AF, there are two dimensions to it. It's either you are trying to do a catheter ablation for the AF directly to convert the person to sinus rhythm.
Sinus rhythm.
Are you getting me? So that is where you go to the pulmonary veins and isolate the pulmonary veins because that's strong location for the stimulus for the air. That's what the trigger is. Okay. So in that case, you are trying to convert the patient to sinus rhythm. But when you talk about AV nodal ablation, it's also a catheter ablation. You are not trying to convert the person to sinus rhythm. Okay. You're actually inducing a complete block. So if you look at the slide in front of you now, it says clearly atrioventricular nodal ablation, true or false?
Yes, Chief.
AV nodal ablation will not convert the patient to sinus region, will it?
No, it will not.
Yeah. So what you are purposely doing is to convert the person to a completer block. Now, when you convert to completer block, you have removed the atrial trigger.
Component.
Is
Yeah.
worsening the heart failure. Okay? Then you can now proceed to, if the patient now has a reduced ejection fraction, you can proceed to do a CRT for the patient in order to improve biventricular pumping, to improve the ejection fraction. Okay? If the patient does not have reduced EF, then you can now proceed to do a pacemaker or an ICD for them. So there are two sets of patients now. So let's get it clearly. Set number one, patient has heart failure with reduced ejection fraction worsening by AF. I'm sure we've made diagnosis like that in clinic. Have you? You see a patient with heart failure with reduced EF and is what triggered or precipitated by atrial fibrillation. True or false?
Okay.
Are you getting that?
Yes, sir.
I want to be sure I'm audible.
Yeah, Prof, you are
Yes, you
audible.
are, sir.
Okay, so in that kind of patient, so that you can now to isolate therapy. So in that kind of patient, there are two ways to managing this patient. He has heart failure, reduced EF, precipitated by AF. So you will treat the heart failure, you will treat the AF. You try to do either a rate or rhythm control. If the patient is still very symptomatic, you now are now left. Remember, the guideline says 3 months, right? Optimal medical therapy. So after that 3 months, you are now left to make a further decision because the patient is still very symptomatic. So you are trying to consider that means you've tried to do rhythm control, but it's not getting it. Rate control is not improving. So in that kind of a patient, you can try to talk about doing ablating the pulmonary veins, okay? Catheter ablation for pulmonary veins to remove the patient from AF. If that is not possible, the next option for this patient, who is a candidate for a device, is that you can go ahead and ablate the AV node so as to knock off atrial triggers. Okay, so when to ablate the AV node, that means the patient is in completer block now, right? So that means that the patient is not dependent on his ventricular escape rhythm. So in that kind of patient, put in a device to control the ventricular rhythm, which is basically doing a biventricular pacing. So they would improve with their ejection fraction because you have done a CRT for the patient now, but it's a bi-V CRT, no atrial components. Okay? Are you getting me?
That's true.
Now, the second set of patient is patient has heart failure, preserved EF, and has AFib. Okay? Or patient has AFib with fast ventricular response, all those things that affect, but he has normal EF. That kind of normal EF does not need a CRT, right? So that kind of the patient, if you have gone for catheter ablation for the pulmonary vein and it's not possible, then the next option the patient has is to what? Ablate the AV node to remove the atrial trigger and now do a pacemaker for the patient. Because moment to ablate the AV node, the patient is in completer block. Then you now do a pacemaker for the patient to what? Take over the ventricular rhythm. You get what I mean?
Yes, sir.
So I'm trying to differentiate AV nodal ablation from pulmonary vein isolation.
That's true.
Creating this clinical scenario. So they are talking about different types of patients. Okay.
Thank you so much, sir.
Thank you very much.
Well, I just have a question, please. So how do they take out the atrial component from the CRT? Is it the programming?
Okay, so good. So let me just quickly answer your question. So there are two ways to this. Now, so the moment, so this patient, so let's say a patient has atrial fibrillation, okay, and has heart failure. And in a setting where you don't have opportunity to do AV nodal ablation, what you can do is, it needs a CRT, you put the CRT, but you will not put a lead in the atrium.
Oh, okay.
That's one way. Or you already put a lead in the atrium, then you go to your programming and knock off atrial. You know how when we talk about programming, we have different types of modes, right?
Yes, sir.
So you can switch the atrial mode.
Okay. So you take off the atrial sensing?
Yeah, the atrial mode, you just take it off.
Okay.
You get what I mean?
I
You
get
know
it.
all your VVIR, all those stuff. You
Yeah,
just remove
chamber
it.
sense, changer pace, and yeah.
You just go to VVIR and you just focus the patient only on ventricular pacing. You get that?
Yeah, it's
So
clear,
that
Prof.
is
It's clear, Prof.
now patient that you have done AV nodal ablation for. If the atrial component is still very disturbing, and there's no need to put an atrial lead. You get what I mean? Because if you put the atrial lead there, it will still be sensing fibrillation, because AV nodal ablation does not mean you have removed atrial fibrillation, Abi?
Yes, Prof.
Just block the atrial triggers from entering the ventricle, but that does not mean atrial fibrillation is still there. So that kind of patient does not need an atrial lead. You get what I mean, sir?
Yes, Prof. I do get it.
Okay, thank you.
Thank you, too, Prof.
Prof, please let me also ask a question. But that kind of patient, would the patient still need anticoagulation because of the risk of stroke?
So always you get it at the baseline. Moment the patient has AFA, anticoagulation is still. You should know why the patient should still need anticoagulation. Don't forget, because you have ablated the AV node, that does not mean that clot can still not form in the atrium. Sure, but I just explained that fibrillation is still there. Yes or no?
Yes.
The atrium is still fibrillating now. It's just that it's not communicating the fibrillation to the ventricle. Abi? That atrium that is fibrillating can it still abort clot? Yes or no?
Yes, it can.
Can the clot dislodge into the ventricle? Yes or no?
Very well.
So with this thing anticoagulation, yes or no?
Yes, they will still need. He answers it, yes.
So thank you very much, sir.
Thank you very much, Prof, for the very important contributions and clarifications. In the absence of any further contributions, do we have any other contributions or questions? Like, in the absence of that, I want to say a very big thank you to Dr. Ozor Chibuke for this presentation. And God willing, we'll meet again tomorrow to continue the guideline presentation, same time tomorrow. The topics are on the rota. Let's refer to them, both curriculum presentations and the guideline presentations, and also the MCQs. As much as possible, we want all hands on deck. We know it's tiring, but let's help each other so that the stress will ease. Thank you very much and have a wonderful evening.